speech by Mr. Ravindra Jain. Agenda 2, Introduction of HCG Hospital by Mr. Sehgal. Agenda 3, our first clinical session on Robotic-Assisted Surgery in GI cancer. Agenda 3, our second session will be covered the past, present, and robotic futures of robotics in Uro-Oncology. Agenda 4, Q&A and open floor discussion for all participants. Agenda 5, closings announcement. Dear doctors and valued customers, welcome to our CME events. As per our first agenda, I would like to invite Mr. Ravindra Jain for the welcoming speech.
Hello, good afternoon, Minglava. I'm Ravindra Jain, Managing Director for Khora Consultancy. Most of them may be knowing me because I'm in Myanmar from last 16 years. I come Myanmar as a country manager for Ipca Pharma. Then I shifted to Glenmark. You may be using still Ascoril, Telma, Perigard. These products, Glibo, are mostly launched by in my tenure. In 2016, I started my company called 4R Consultancy, which we are doing the medical tourism, and we are working with SCG Hospital from last 7 years, which is one of the biggest chain of cancer hospital, and they are the biggest chain of cancer hospital, single specialty in Asia, not only even in India. And we are partnership with Victoria Hospital for our OPD doctor and today event. So thank you very much for Victoria team for doing fantastic job. So in 4R Consultancy, what we are doing, till now I have arranged almost 36 Myanmar doctors for getting the training in India, different hospitals that include hematology, oncology, gastroenterology, cardiology, endocrinology. So if any doctor want to do some training in India for 2 week, 4 week, it depends on your specialty and your requirement. We can help you to get the updated knowledge. Another thing, for our consultancy, our company provide air ambulance services and emergency medicines. Especially those medicines are not available in Myanmar in a small quantity, like some cancer drugs which are not available in Myanmar. You can contact us. We can get it as soon as possible at very reasonable price. We have our tie-up not only in India, around the world. So we have connection from US, UK, from anywhere we can get it, the medicine for your patients. And today objective of this program is to bring the India talent and meet the Myanmar talent so we can complement each other. So we have our 2 very prominent doctors. Dr. Karan Sehgal, he is a robotic GI and breast cancer specialist. Once he will start presentation, you will understand by face he look very young, but by experience he got lot of experience. And then beside Dr. Karan Sehgal, Dr. Gaurav Aggarwal is sitting. He used to do previously lot of kidney transplant, but now he become a specific for robotic Uro-Oncology. Still he can do kidney transplant, but I don't think now he do kidney transplant. He is focusing mostly for the robotic urology. They are doing the prostate cancer cases with robotic, where the incision is very less and the cost of robotic surgery in SCG is comparatively to anywhere in the world is the most economical. Before I close my opening speech, I want to tell you one thing. I have experience working with doctors from everywhere in the world, but Indian doctors, you will find they are one of the best, just because it is not that they are Indian so they are the best and they have more knowledge than you. It is not like that. they have got more experience than anywhere in the world, doctors. Like in India, one doctors do lot of surgery. What Singapore doctor do in 1 month, they do only 2 and 3 days. So they got more experience. So their results are much more better. I give you one simple example. Last year I was the president of Rotary Club Yangon. So we have done 1,000 cataract eye surgery for Myanmar patient. Now every month our Rotary Club is doing 200 cataract eye surgery free of cost for Myanmar patient. So I have one of my friend. She's a very well-known lady in Myanmar. Her husband was having a GI problem. I asked her, she said, Ravindra, my husband have a problem, what should I do? So I said, take him to India, I will take care. She said, no, they have money, no issue. They are healthy, rich. So they go to Mount Elizabeth, Singapore, spend $100,000. Nothing happened, come back. After 1 month, again problem. Then again she asked me what to do. I say, go to India. No, I will go to Bamrungarh. Again they spend $50,000 and result not, cure is not there, there is a temporary relief. And after when she gone Singapore, she gone to Bangkok, then last she called me, Ravindra, now I want to go to India. So then she go to India. In India our doctor done the surgery for 16 hours and they take out the tumor. It was not a cancer tumor, but it was a 1.4 kg, something like that. It is then they put this surgery for the students, and then her husband survived 2 years, and then COVID come and he died due to COVID. So what I am telling, because Indian doctor can take much more risk and they got more experience. So we will request, if you have any patient where you think he cannot be treated in Myanmar, please contact to 4-hour consultancy. We will provide A to Z service from visa, air ticket, airport, pickup, drop, Myanmar translator, even currency exchange, Indian SIM card. We will try our best. You don't. And another thing, Kolkata is just 1 hour 30 minutes away from Yangon. It is like a Bangkok. So thank you very much come out and taking time to attend the CME. I hope it will be useful. Thank you very much.
Thank you, Mr. Ravindra, for your deep explanation. Now I would like to invite Mr. Sehgal for your explanation on HPV hospital.
Thank you very much. Namaskar. Mingalawa, I am Souvik Sam. I am heading the international marketing at HCG Cancer Center, Kolkata. So first of all, I would like to thank you all for taking out your precious time and to attend this CME. So for that, we are really grateful for that. We know that today is Saturday and mostly all the OPDs are very much busy. So thank you for coming here. So let me just give you a short brief about HCG, Healthcare Global. The full form of HCG is Healthcare Global. So we are specialized in comprehensive cancer facility, cancer care. So we have more than 27 centers in India, which all treats only cancer patients. Apart from India, we have our presence in Tanzania, Kenya, Vietnam, and all these countries. So where I sit, it's situated in the eastern part of India, which we know as Kolkata. So it is specialized in cancer care only. So we have all the specialties of cancer available at our center, which we can say wide range of surgical oncology, then radiation oncology, medical oncology, nuclear medicine therapy, hemato-oncology, and all these departments filled with expert doctors at our center. So if we say detail about surgical oncology, the thing which depart us from other hospitals is that we have our organ specific expert doctors with us. So who treats only those particular organs on. If I say Dr. Gaurav Aggarwal, who is specialized in Uro-Oncology. So Dr. Karan Sehgal, he is specialized in GI and breast surgery on. Likewise, we have our doctors who are specialized in head and neck surgery, gynae surgery, then ortho-onco, neuro-onco. Likewise, we have all the organ-specific doctors who treat only those particular super specialty. Due to that, we are able to give the super specialty services, to the patient. In medical oncology, we do give chemotherapies, then immunotherapies, targeted therapies, hormonal therapies, all these therapies at our center. In radiation oncology, we have the most advanced Regisect 9 machine, which is the latest one in throughout the world, and that in India it was first installed in HCG only. So through which we are able to give accurate and specific tomotherapies, so which is another an advanced way of giving radiation therapy to treat any cancer patients. In hemato-oncology, we treat all different type of blood disorder, blood cancers, like if we say AML, acute myeloid leukemia, then acute lymphoblastic leukemia, then lymphomas, multiple myelomas, all this type of blood disorder we treat at our center. We do bone marrow transplant on a regular basis. Also, we have advanced way of treating the blood disorder or blood cancer by giving CAR T-cell therapy also. In nuclear medicine department, we have our nuclear medicine expert doctor with us. We give radioactive iodine therapies, then PSMA lutetium therapies at our center only, and without any waiting time. I know in Myanmar there is a huge waiting time for any patient who wants to undergo any radioactive iodine therapy. Like 2 months, 3 months, they need to wait for that. So in our center, within a week, the patient can come, undergo radioactive iodine therapy, and then come back to Myanmar. Within a week, this can be done. We have our interventional radiologist who treats microwave ablation, then radio frequency ablation, which helps to cure from different type of liver issues or liver tumors or liver cancers. More detail doctor will explain. So this is as a non-medical person, I can just say that yeah, these are the facilities we do have. So this is a part which we can say in medical side which we have as far as the technology is developed, as far as the expertise with us. So we are treating the patients. Now another part is that the logistic services which to be given to any patient who are coming from any foreign countries. Like if I say any patient coming from Bangladesh, from Myanmar, from Nepal, Bhutan, from wherever they are coming from, they have their certain things which is not similar to our culture, and which makes them which is very difficult for them to deal at that point of time. Like if I say from Myanmar, if the patient are coming, and mostly people don't know about English language or any other language rather than Burmese language. So for them we have translator, dedicated Burmese translator who can the time patient land to in Kolkata airport. So they will pick them from the airport. They will drop them to the guest house. That guest house is being booked by us only, where they can stay very safely, where they can they can make their own food, because mostly we saw cancer patient needs to stay for 2 months, 3 months for during the time of their treatment process. So and it's not it's not familiar for any person who wants to, even though I'm an Indian, I cannot have daily food from the hotel. So I would like to have something which is very lighter and good for my health, which I can make in my home. So for them, there is a facility they can make their own food. There is in the guest house only. All the utensils and everything is available over there. During the time of the treatment process, they can for any help like SIM card arrangement, extending of their visas, or any other issues, anything. So that we deal with the patient so that they are not concerned or they are focused to their treatment, not other things. So I think that's all I can say about my hospital. If anyone would like to ask anything, please raise your and you can ask any questions regarding the services or regarding anything which we are providing at this point of time. So I thank you, madam.
Thank you, Mr. Sehgal, for your informative explanation of PCD Center. Now we move to our educational section. I would like to invite Dr. Sehgal for your topic.
I know it's tough after a lunch session to just sit and concentrate, but I will just be showing you some surgical videos and some pictures, and there won't be any text, so that everybody can be interested, and let us have an interactive session. If you think you don't understand anything, you ask me to stop. I'll stop and let you know what that thing is exactly. So this part has already been covered, but not repeat that we are from HCG hospital. We have around 30 hospitals all over India. So we come from Calcutta, the city of joy in India, and we have been getting few patients from Myanmar. Already we have operated them and they are doing well. One of such patient had come this morning as well for the morning session. He had underwent a robotic-assisted low anterior resection, and this presentation is purely for you to understand that how surgical oncology has been making recent advances and what all things can be done. Organ preservation is the most important thing which we are looking for nowadays, basically for all the organs. For my area of interest is the CA breast. We are doing a lot of breast conservative surgeries. How do we achieve is with advent of frozen sections, then fiducial markers which are put before giving chemotherapy, before giving NSCT, we put fiducial markers, and that is why how we are able to achieve these breast conservative surgeries. So in this, this is a mammogram of this patient in which fiducial marker was kept before chemotherapy. On the day of surgery, we have done a wire-guided localization of the tumor and then taken them for surgery. This is the specimen mammogram which confirms that the fiducial marker, this is the fiducial marker with the wire, that it is there, and that confirms that you have taken the whole tumor out. This is subsequently sent for frozen section as well to confirm the margins of the tumor as well. This is another picture of specimen mammogram of the specimen in which it confirms that the marker is out. So these are the pictures of these patients who have undergone surgery. Few are done with a round block, and we have now accepted and started to do a lot of oncoplasty techniques to just fill the gap, maybe type 1, type 2 oncoplasties, and few of the plastic surgery techniques with perforator flaps to just cover the defect. This is a general picture when I do axillary resection. We clear out whole of muscle fascia as well. So this is one side is the nerve of latissimus dorsi, and the other side is a long thoracic nerve. All the fibrofatty tissue between the things is being taken out. Even the muscle fascia has been removed. We expose the axillary vein completely. Even the adventitia of the vein is taken out. I think everybody is familiar with latissimus dorsi flaps, and this is a regular affair. This is a mini ND flap which was kept, and another is a big defect which we had to be covered with LD flap. Believe me, there are male breast cancers, and in last 5 years I might have operated 3 or 4 male breast cancers as well. So this particular patient had a very bad tumor. It was involving pectoralis major fascia as well, and I had to expose the ribs. Even the ribs were exposed. The whole of pectoralis major was taken out. I had to involve a plastic surgeon in this case. No surgical oncology cases can be done single-handedly. You have to have big teams. Sometimes we require plastic reconstructive surgeons. Sometimes we need a urologist with us to take care of stuff. We work as a team rather than a single-handed person. So this plastic surgeon, he had done a contralateral pectoralis major fifth flap to just cover the defect. This was a case of ovarian tumor, which someone had done FNAC outside to confirm it. All the ovarian tumors or SOLs should not be FNA'd or biopsied. They increase the stage of the tumor from 1A, 1B2 directly to 1C. If FNAC is done and it comes because it leads to dissemination or seeding of the tumor. So no such tumor should be touched with needles or biopsies. They have always have to be taken up for exploratory phlebotomies and taken for frozen section. If they come positive, you go ahead to a psychiatric ductal surgery for this patient. Unfortunately, this lady had already got FNAC done outside because nobody was able to diagnose it. Later, after diagnosing, she had come to me. I had calculated PCI score for her. PCI score is the score which we do to see what all tumor is there, peritoneal carcinomatous index, just to confirm what is the resectability of the tumor. This is a complete picture of cytoreductive surgery for this patient, in which you can see the external iliac vessels are exposed. Pouch of Douglas peritoneum is taken out. Where is the bladder? Bladder is completely mobilized and outside, somewhere here. The bladder is completely mobilized and it's outside. So this is what we call is a complete clearance of tumor. This patient had, this is a primary tumor in the uterus and the ovaries. That is the right-sided ovarian mass with omentectomy, infracolic omentectomy, along with the small boxes containing all the pelvic nodes. And there is something known as pan-peritoneectomy specimens which you have to take if the tumor is not gone to peritoneum, just to confirm that the peritoneal disease is there or not. So this brings me to HIPEC surgeries. What is HIPEC surgery? It is hyperthermic intraperitoneal chemotherapy, which is administered in patients with peritoneal disease. It can be ovarian cancers, stomach cancers, colorectal cancers, all can be subjected to HIPEC treatment. But there is a prerequisite for this procedure, which is you have to achieve CC0. You have to completely remove all the macroscopic disease. There is no point of putting HIPEC if there is macroscopic layer disease which is left behind. It will, believe me, it will not work. For my personal view, I generally don't do HIPEC in patients if the stomach PCI is more than 6 to 8. In colon, again, if the PCI score is more than 6 to 8, I don't do HIPEC. And in ovarian cancers, even with high PCI score, there has been a lot of OS and DFS benefit, overall survival, disease-free survival benefit. So it's been done for mostly for these ovarian cancers. This is one such patient. I generally follow open colossal technique, in which I open the abdomen from pubic symphysis to xenosternum. We lift the abdominal walls like a colossal. Again, heated chemotherapy is administered for 60 to 90 minutes, depending upon the etiology, depending upon the primary disease. This is a HIPEC machine. You see, there are 4 probes which go inside the abdomen of patient. 2 probes, 2 pipes are taking the chemotherapy inside, and 2 pipes are taking the chemotherapy out, the drainage pipes. In all those 4 pipes, there are these temperature probes which continuously tell you what is the temperature which is being maintained. You have to maintain it around 42 to 43 degrees. So you can see in this picture as well that all the 4 probes are maintaining temperature of 41 to 42 degrees. Again, coming to the actual topic for today is what is robotic-assisted surgeries. I am pretty sure that you are aware of robotic surgeries. What does robotic surgery mean? Are you aware, or is it a totally alien topic for you people? Are you aware of robotic-assisted surgeries? Yes. Okay. So it is the machine. Is it the machine or the man behind the machine? Of course, it's the man behind the machine who operates. Those 4 robotic arms are controlled by a robotic surgeon sitting in the console in the same room in which the patient is getting operated. Almost all surgeries can be now done with help of a robot. I am not a propagator of Da Vinci system, but I have been trained on Da Vinci system since 2018, so I use a Da Vinci system now as well. And according to me, that is one of the most advanced and capable robotic system. This is a small video in which I am explaining what our robotic arms and parts are.
Friends, my name is Dr. Karan Sehgal. I am a surgical oncologist at HCG Cancer Center, Kolkata. What is robotic surgery? What are the uses? What are the advantages? And where all robotic surgery is done? There is a common misnomer and a disbelief that robotic surgery is done by robot. Robotic surgery is done by a surgeon through robotic arms, which are controlled by a surgeon. So let me tell you something about the robotic parts, which will help you in better understand. This is a surgeon console on which the surgeon sits and controls the robotic arms. This is a patient cart on which robotic instruments are kept applied over this, and through which the surgeon controls these. So these movements are controlled by surgeon, which helps us in doing the surgery. Coming to the third part, this is a vision cart, which stays to the patient's bedside, and everyone else in the OT, the anesthetist can see what all is going inside the surgery. Let me tell you something about the uses and advantages of robotic surgery. There is definitely shorter recovery time.
We'll just skip the video now. So, like I mentioned, this is the console. This is the patient cart, which is near the patient, on which these robotic instruments are kept. And this is the patient vision cart. So, what are the uses? Why we are moving from traditional or even laparoscopic surgeries to robotic surgery? Again, on laparoscopic surgery, the scar is very minimal. The scar of the robotic trocars is only 8 millimeters long. The vision is very good. We get a 3D 10x magnification, 3D vision with 10x magnification. You can actually perceive the depth as well, which I know with 3D laparoscopic cameras you can do that, but sitting on a robot with such a good magnification and vision and being able to perceive the depth in which your instruments are working is something which is phenomenal. Surgeon's fatigue is one point, but I would really not say that surgeon's fatigue is a thing which should be taken into account. Definitely the patient goes back home early. Like I mentioned, that patient we had operated on Monday and the patient was discharged on Saturday. And he was back in Myanmar in, I think, 2 weeks' time. Robot can actually imitate your wrist movements. So that is what it is. It is the 7 degrees of freedom, the movement freedom up to 7 degrees which a robot can do. So the moment I am doing a wrist flip like this, the robotic arms exactly imitates it in milliseconds. There is no lag time. It is not like I am doing the movement now and it is taking 1 second to imitate that movement. It imitates it within milliseconds. So I'll just take you through this surgery. The purpose of this video is not to teach you surgery, but to make you appreciate the robotic movements and how these wrist movements, which I'm talking about, how those are imitated, and how small and precise these instruments are, and till how depth and till with what precision these work. So this is a case of rectal sigmoid tumor. We had planned for a robotic-assisted anterior dissection for this patient. We do a medial to lateral dissection in this patient, which is oncologically and minimally invasively planned. So I've just started dissecting in the, trying to make a plane in mesocolon and rectoperitoneum. That is a avascular plane. So this video is at 4 to 6x, that means 4 to 6 times faster, just to reduce the time. You saw I just zoomed in my camera and went inside. The part which I like is that you can actually control the camera as well. So again I zoomed in and I went inside. I'm trying to find a very vital structure which has to be saved all the time. I've zoomed in again, you see the clarity of the vision, it's 4K clarity, and that is the ureter which I'm trying to save. I've safeguarded the ureter and my dissection has moved cranially. There is something called a central venous ligation and D3 lymphadenectomy in tumors, in cancer surgeries. We always, you see that small node which is being taken in the specimen. Those nodes are very tough to see even with naked eye. So I'm just trying to delineate inferior medial mesenteric artery pedicle, which comes around 1 centimeter above aortic bifurcation, and trying to take it at the origin, that is at the root of the vessel. I put the lega clip. Again, you saw there is that small node which is being taken in the specimen. So again, I'm taking as much as notes as possible in view of doing a D3 lymphadenectomy. There is a vein which is again safeguarded, that is inferior mesenteric vein. So, most of the times I'm trying to save in IMV vein as well. Again, those are the D3 lymph nodes. I generally take these pedicles with LigaSure until the patient is elderly and I'm having risk of atherosclerosis. Yeah. So my medial to lateral dissection is already completed. So I move laterally. This is the classical open surgical technique in which you go along the line of told. That is again avascular plane. I will again delineate the structure which I had saved initially, that is the ureter. That is the ureter showing you peristalsis. I've already done the medial dissection part earlier, so I'm boldly cutting and now going from laterally to medial. Splenic flexure mobilization is sometimes not required if the sigmoid is quite redundant. So I leave that to the last. If it is required, I take it. If not, I will just avoid it. Just see those precise small movements with the robot which are being made. Like I told, this is a accelerated 4 to 6x video, so you might think that I operate quite fast, but that is not the case. I generally operate very slow. So I'm just trying to make some space cranially and caudally. This is again the tumor on the screen. Like I mentioned, we do central venous ligation and D3 lymphadenectomy. I've just lifted the tumor again and trying to assess where exactly my cranial and caudal dissection will happen. This is a robotic stapler which is being inserted, and the distal part of the colon is divided. Now the proximal part is being divided. I'm just again now reassessing that my eliminate colon will reach to pelvic brim or not. So if it reaches pelvic brim, I generally don't mobilize the flexion anymore. So I've now opened the abdomen, taken out the remnant tumor, colon, and inserted my circular stapler. My colleague has inserted the circular stapler from the anal verge. This is the special mode, ICG mode, the 5-fluid mode, which ensures and tells me that what is the vascular status of the anastomosis. We are always worried about the vascular status. So this special mode will confirm that the blood supply is there and the chances of an anastomotic leak is almost negligent. I generally place a ADK drain as well, just near the anastomosis, so that if there is some leak, that can be picked up early. I did not make any divergent stoma ileostomy for this particular patient because this was an upfront surgery of sigmoid colon, and I generally don't put a diverting stoma if it is upfront colon surgery. That's it. Thank you.
Thank you, Mr. Gaurav.
Okay, like I mentioned, there is this ICG mode in this robot, the 5-line mode, in which you can actually see where exactly is the cystic duct going in, joining in the CBD.
Okay.
So if in laparoscopic surgeries the chances of injury of cystic duct is 1 in 300, in robotic surgery according to me that is negligible. I don't think so. With ICG mode you can actually injure the cystic duct, almost not possible because of this special mode. So you see that is the cystic duct running in the CBD. So all those difficult, tough laparoscopic cholecystectomies can be done with this, and you don't have to worry and think about them. No need to struggle. Okay, thank you. Thank you. So if there are questions, you can definitely ask.
If anybody have any question, please.
So those videos are not to teach you surgery, but just to understand the movements, the precision with which robot can be done, and the kind of vision which we get. Believe me, I have stopped offering laparoscopic surgeries to my patients now. I only offer open or robotic surgeries. I don't offer laparoscopic surgeries. Because of the cost factor is also reduced now with the other companies bringing in the robots. The charges of robotic surgeries have reduced and it is quite comparable to laparoscopic surgeries, at least at our center. Thank you.
Thank you, Mr. Gaurav. Now we
Good afternoon, everyone. Well, I'm Dr. Gaurav, and I look after the motorworks department of our body. That is, if there's anything wrong in the plumbing of the body, kidneys, the pipe that connects the kidneys to the bladder, the ureter, the bladder, the genitalia in males and females, that's what I take care of. So today we are talking about advances. Now, advances in surgery haven't happened overnight. It's been a gradual increase. We've come to the tried and tested open surgery, then came in laparoscopy, 3D laparoscopy, and now robotics. But again, before we start, hashtag it's robotics is not a panacea. It's the doctor or the man behind the machine, like my colleague just said, who is the most important person. Because we're dealing with cancer here, and our first priority is to have a safe surgery and clear margins. So if I talk about my department, about the motorworks, how does robotics come in? What was there before? Where are we now? And probably is robot the future for everything? Let's see. So how did this term robot actually come in? From the era of Leonardo to Da Vinci. Per se, this term robot is a term used in a play conducted in the Czech Republic in 1920s called as Rossum's Universal Robots. That's where this term robot actually came in. So it's basically telling us that it's a bot. It's an instrument in our hands. It's not our master. We are the masters and it's our slave. It helps us to cure or give better outcomes to our patients. As we evolve over time, so has the robot. We have the Da Vinci, which is one of the initial companies who brought in the robot. That's how it used to look like in 1999. That's how it is in 2017 and gone up much better to the latest 4th generation robot. Now, robotic surgery is not without its own challenges. A surgeon can't sit today and say, I'll do a robotic surgery on my patient. That's not how it works. There's a learning curve. The most important thing is there is no touch sensation, which is most important for a surgeon. You have that touch sensation even in laparoscopy. It's not there in robotics. Your vision is your judgment. So that's the learning curve. There are ups, there are downs, there are pitfalls, but finally, with time, eureka. We do reach our goal. So much so that our finger movements are translated inside the patient. There's no time lag. As already initiated by my colleague, there's absolutely no time lag at all. If we look at India, there are a lot of Da Vinci installations, 5 of which are there in Kolkata, which is about an hour and a half from Myanmar by flight. Now, robotic surgery, yes, has its advantages. What are the advantages? Because it's done through small keyhole incisions, which are probably smaller than your laparoscopic ports. There are 8 mm ports. So there's less trauma, consequently less scarring. Less scarring means less infection, less pain. You're ambulating faster and you go home earlier. But there are always two sides of a coin. There is an initial capital investment, maintenance, and training. Training of the surgeon to get over that lack of sensory feedback, lack of effects. That takes time. Now, in your waterworks, these are the major procedures which can be performed for oncology by a robot. The emergency surgery is in red because that's when you have to go back to your time-tested open surgery. You don't have time. Talk about literature. Just to quickly get you through literature, boring you a bit before we go to the actual videos. Now, we all know that for a prostate, for a disease which is confined to the prostate and not spread, if the patient is a candidate for robotic prostatectomy is now the gold standard of care. You can have a look from 2006 to 2016 is what data is available. It's gone up tremendously, comparing it to laparoscopy or open surgery. It's gone up even further. I think if you look at it now, there would be no open surgery at all. This is how a typical post-robotic prostatectomy specimen looks like. You can clearly see the prostate with both the vas, the seminal vesicles, the apex, and in this case even a part of the urethra. This is done when there is disease down here. You want a negative margin, you take a little bit of the urethra to get a negative margin. Now the one in the center, I've written it as post-laser TURP. This patient had undergone a transurethral resection of prostate, a standard procedure for urinary symptoms. Those chips came out as a malignancy. It was confined to the prostate, and that's the specimen we got after a robotic prostatectomy. Let's go up, down to up, go to the kidneys. In kidneys as well, our main aim is partial nephrectomy or nephron sparing. The numbers of robotic procedures have gone up tremendously. Now I'm just showing you numbers have gone up. Does it actually benefit the patient? Yes. it is less morbid. And for a doctor, in terms of functionality, there is a less incidence of upstaging of chronic kidney disease. The chronic renal insufficiency as compared to open and laparoscopy is almost negligible in a robotic partial nephrectomy. That's the advantage to the patient. These are pictures of, on the right side, the left of the screen is the radical nephrectomy, the entire kidney. You can see the tumor mark with the ureter and clip below. This in the center is the partial nephrectomy, where only the tumor has been taken out. And we've been able to preserve the remaining part of the kidney. And this is of an adrenalectomy. The adrenal is a small gland sitting on top of the kidney. That's how it looks like. So our main aim is to preserve the kidney functions so that the patient can be more comfortable throughout life. This is for a transitional cell carcinoma. Now a TCC is the lining from the kidney down the pipe into the bladder. So you need the entire kidney with the pipe with a cuff of the bladder. This is the bladder cuff. You need a cuff of the bladder to ensure that you're giving the patient the best possible outcomes. So that's the one on the right, and this is for a left nephrouretrectomy with bladder cuff. Now what about cystectomies? Cystectomies or bladder removal for bladder cancers, which are muscle invasive, are coming up. The numbers have increased over time. Maybe because it's not only about taking the bladder out. The urine has to treat. It's about reconstruction as well. So those numbers in terms of robotics are not that high when you compare to kidneys and prostates. Now this is something which is very interesting. In a penile cancer, once a cancer penis has crossed a particular pathological stage, the next step is to remove the nodes in your groin, the inguinal lymph nodes. We all know this space is very, very narrow. There's hardly any space. We do open surgery and it's got a plethora of complications. Skin-related complications, lymphedema. The patient will come back to us, the leg is swelling, what do I do? There's a drain, doesn't come out. That's done robotically. And this is exactly the picture of the textbook at the saphenofemoral junction. You are all aware that there are three major branches of perforators at the saphenofemoral junction. That's how it looks like on a robot. That cannot be aped either with a laparoscopy or open. And that's the lymph node yield. There's no difference in the lymph node yield. In fact, the patient goes home on the second post-operative. He doesn't have to stay in hospital more than 3 days. So I'll just show you briefly a small video regarding that. Same thing, the groin node dissection. I'm just showing you a small 2.5-3 minute clip of how it's done robotically. The main approach is lateral. We're going from the lateral side to the medial side. It's not from below upwards. So all the folds are done on the lateral aspect. The robot comes from the side. Now, prior to that, this is a small setup which is required to create the space. A balloon is used, it's similar to a retroperitoneal approach, where you have to create the retroperitoneal space. You have to create a plane. This is a simple thing done with the help of a gloved finger. That's the surface marking and the position of the patient. As you can see, this is our femoral triangle. Similarly marked on the patient on the right side. That's the port being done on the lateral aspect. That's how they look like once the ports are placed laterally. Remember, it's a very narrow space. The first thing you see once you have created the plane is your lateral muscle, the sartorius. We all know that's the first muscle we'll see. The fascia over the sartorius is lifted. We don't leave the fascia behind. We don't want any microscopic disease left behind as well. Once that is done, the dissection is now continued from lateral to medial and then from inferior to superior, that's caudocranial. It's done simultaneously. Once we perforate that, we get the apex of the triangle, the femoral triangle apex is this side, the groin is that side. we come to see the adductor longus, the medial muscle. So it's sartorius on one side, the adductor longus on the other. Once that is done, we are gradually dissecting to find our femoral vessels, the main femoral artery, femoral vein. So as you can see, the artery is just now coming into view. That's the artery over here, the femoral artery you can see is coming into view. The vein is medial to it. That's the vein. FV, the femoral vein. So it's a gradual push, pull, and that's how it looks like once it's almost done. That's the saphenous vein originating from this femoral junction, the SFJ, the saphenofemoral junction. We are able to preserve the saphenous vein in this. That reduces lymphedema. So the entire saphenous vein is taken off from the roof, the nodes are on the roof, it's taken down. We have to maintain a uniform flap thickness to ensure that the flap remains viable, the skin remains viable. So the flap thickness is uniform, the saphenous vein is brought down. It's brought down onto the muscles, along with the entire lymph node pattern. That's the same picture I showed you. The great saphenous vein with the 3 branches at the saphenofemoral junction. This view, believe me, having done a lot of laparoscopic groin, I've never seen it. It's only with the robot that this is seen. So you're able to preserve and identify each and every perforator as well. So that's the vein, that's the artery, that's the saphenous vein, and we're going up. The upper margin is the external oblique aponeurosis. It's a triangle. So we have to get the entire nodal tissue out. That's the nodal tissue being taken out. We're going up to the external oblique aponeurosis. And there's no bleeding in this. I don't need an assistant. There is no assistant with me in this. There's one camera arm and 2 robotic instruments which I am controlling from my patient, from a surgeon console. As you can see, the entire saphenous vein is getting bared and we are sparing it completely. So that's the saphenous vein and we're taking off all the tissue adjacent to it. This is the nodal bulb which I'm putting in my left hand instrument. That's the vein getting completely cleared. We've cleared it laterally, we've cleared it medially, we've cleared it superiorly. The apex is there, it's taking it off from the apex. That's the great saphenous vein being spared completely. That's how we assess the flap thickness at the end of it. Uniform redness, those are the scars, the 8mm scars. Maybe you have to extend it to about 1 centimeter to get that tissue out. That's the lymph node yield as well. You got 10 nodes on one side and 12 on the other in the final histology. And that's day 1. That's how it looks like, and he's home on day 2. So we all know what are the advantages of a robot, giving us that kind of vision, which is not possible anywhere. You need an assistant, sometimes you don't even need an assistant to help you out on the patient side. It's all under your control. So, what's our ammunition? Our robot is our ammunition for this, yes? So I'll just show you basically a small 5-second clips of how it is actually working within the robotic world. So that's the surgeon console where we sit and operate. The robotic instruments are going in through the robotic ports, which are 8mm ports. That's the team at work. That's the patient side assistants. You can see, they're seeing through the monitor, through the vision card, which Dr. Karan had explained. That's your vision card. I'm there. I don't have to take my head out. I can speak through it, and my assistant can hear on the bedside. That's my assistant team having a look on the monitor, exactly what I'm seeing inside there. So they're having laparoscopic vision here. That's a robot in the center that's docked onto the patient. This is a live overview of how actually we work in our robots. That's the vision. For a pelvic surgeon, we know that's the dorsal venous is complex. This is a prostatectomy being done. That kind of vision and accuracy for the DVC is not possible either open or laparoscopically. And our mission to make the patient as comfortable as possible. Just have a look at this port sizes. Look at this cars. 8mm small cars. Don't even need a dressing, a small band-aid works in everywhere. And that's the board of its done job. So yes, if I come back to the waterworks, these are the 5 main neurological symptoms. But one red flag, which I'm sure all of you know, is red urine. Any redness in your urine or doubt of blood in urine is something which you cannot ignore, even if it's once. Coming to costs, we'll all say that we have to navigate these costs very, very wisely. You're getting in new technology, it's going to be expensive. Why can't we do it laparoscopically or doing a robotic groin node? We're getting the same outcomes. How does it matter to the patient if I can see better or not? No, we have to navigate these costs very, very wisely. And it's not that I'm telling you this, that's what WHO says. So in terms of Indian healthcare, how do we stand? This is 2024 data from the World Health Organization. The most expensive healthcare is in Greece. You can go down the list, I've given you the top 15 expensive nations. Where does India lie in this? As per them, it's very, very affordable. But affordability or low cost doesn't mean a quality compromise. That's what they also say. That Indian doctors lie among the top 10. But basically because of higher volumes of patients, they get higher skill sets. So this is all a WHO data, not my data. So yes, nearly 20 years after robotics, urology has been introduced, it's become a common practice. For certain procedures, the increased costs of the system and the maintenance get offset by reduced complication rates, reduced hospitalization, less loss of manpower hours. And like I said, it's not one size fits all. So it's not that we have to do a robot on everything. That's between the patient and the surgeon. The surgeon decides what is best for his patient in his own hands. So I thought I should give you a SWOT analysis of what a robot helps in terms of urology. For a radical prostate and a partial nephrectomy, absolutely, it's a mandate. Pelvic surgeries, yes. Surgeon comfort, you can see, I'm sitting and operating. I don't have to stand for 10 hours. The weakness is in emergency, where we go back to our tried and tested open. Costs slightly higher, but again, we know how we offset those costs. The patient staying in hospital for 7 to 10 days in open surgery, going home between 2 to 5 days in the robotic surgery. There is a learning curve. Opportunity in India is now making India robots, and other robots have come in. But again, something which is 20, 25 years old versus something which is 2.5 years old, I would rely on the older one. And again, lack of basic open surgical skills. This is something we are seeing in the newer generation of surgeons. The moment they finish, they want to go to the robot. Emergency, we have to go back to our hands. So that's my team. That's the team with the robot. And yes, robots are redefining the future of healthcare due to all of those benefits mentioned there. Minimally invasive, precise, like a surgical strike on the disease. Shorter hospital stay, less pain, blood loss, lesser infections, and the patient is home sooner, back to his home, back to his life. So I'll say thank you very much for a very, very patient listening. I'm not going to bore you with any more videos. I just wanted to show you that a robot can work in such a narrow space in such a better way. Thank you very much. And we're all open for questions either now or whenever.